Good afternoon and welcome to Day 4 of the Australian Longitudinal Study on Women's Health Symposium. My name is Leigh Tooth and I'm Deputy Director of the study based at the University of Queensland, and I will be the moderator for today's session. I would like to begin by acknowledging the traditional owners and the custodianship of the lands on which we meet today. I pay our respects to their ancestors and their descendants, who continue cultural and spiritual connections to country. I recognise their valuable contributions to Australian and global society. I also welcome attendees from the Australian Government Department of Health and other guests, and hope you find this symposium of interest and relevance for your work. Today's session will include 3 talks on women's reproductive health and reproductive health service use. Firstly, I will give a presentation on prevalence and sociodemographic and health behaviour variations in contraceptive use. Next, Dr. Melissa Harris will talk on the data linkage perspective of contraceptive use. And finally, we will have Dr. Katrina Moss, who will present about pregnancy and assisted reproductive therapy. There will be 2 question and answer sessions, one following my and Melissa's talk and one following Katrina's talk. To post a question for the question and answer session, please post them to the Poll EF poll using the link that has been sent to you. We will endeavour to respond to all the questions in the time we have. However, please also feel free to email us afterwards if you have further queries or questions that we might be able to help you with. Our contact details are on the slides, which will be available to all attendees. Can I please ask you to keep your microphones and cameras turned off during the session? If you raise your hand, please remember to lower it if your question has been answered. So let's get started. The first talk by me will begin shortly. My talk will immediately be followed by Melissa's, and then we will have our first question and answer session. I would like to begin this session today with a talk about prevalence of contraception and use of the methods by different sociodemographic and health behaviour factors. To begin with, I will briefly describe the Australian Longitudinal Study on Women's Health for those of you who did not attend the previous sessions. The study aims to examine the social, psychological, physical and environmental factors which determine good health and those which cause ill health in women throughout adult life. So the survey assesses many aspects of women's health: their physical, emotional health, use of health services, health behaviours and risk factors, time use, sociodemographic factors, life stages and key events. The study has been continuously funded since 1995 by the Department of Health and is jointly managed by the University of Queensland and Newcastle. The study consists of 4 cohorts of women, totalling over 57,000 from all over Australia. The original 3 cohorts were randomly recruited by Medicare in 1996. They were 18 to 23 years, 45 to 50 and 70 to 75 years. And these women have been regularly surveyed since then. In 2012 and 13, a new cohort of women aged 18 to 23 years were recruited. This cohort is known as the 1989 to 95 cohort, and this talk will focus on these women. Use of contraception is an integral and major part of many women's lives. Questions on contraception were first asked when the women were aged 18 to 23 years in Survey 1 and have been asked almost yearly, with the exception of Survey 4, until they were 23 to 28 years old. We've asked several questions on contraception, but the one that this talk is based around is the question that's on the slide. Thinking about the last time you had vaginal sex, did you use any of the following? And women could choose as many options as applied to them. The next few graphs will show the percentage of use of different contraceptive methods by the women over the 5 surveys. This one shows the percentage of women who said they were using the oral contraceptive pill. At Survey 1, when these women were 18 to 23 years, use was reported by about 60%, with this declining to around 34% at Survey 6. This next slide shows the data for condom use in the red line. This was used by about 45% of women at age 18 to 23 and declined to around 30%. So the pill and condoms are the most common methods of contraception used by women across their reproductive lives. And I will note that women could choose more than one type of contraception, so the percentages do not add to 100. This slide shows the addition of the implant Implanon in the purple colour. You can see that Implanon use has remained fairly steady across the surveys at around 10%. Now we add the data for Mirena, the hormonal IUD, in the orange colour. And you can see that this use was very low to begin with at around 2%, but it increased into about 13% by the time the women were 18 to 23 years, 23 to 28 years. This slide shows the use of the other forms of contraception, including, for example, safe period method, natural family planning, withdrawal method. So use of these other forms of contraception remain very low at only a few percent. Finally, we add the data for no conception in the dark blue colour. This doubles over time, so that it's about 20% by the time the women are aged 23 to 28. Now, the next 3 slides will show the transitions in contraceptive use over the survey. And these slides show the complexities and the multiple changes that women make in this early phase of their reproductive lifespan. This first column shows the proportions of women at survey 1 by the different types of contraceptives they used. For example, women using no contraception are represented by the dark blue band at the bottom of the column. Women using the pill are shown in the green band. Women using condoms in the red band. The orange band is women using the long-acting methods. And the light blue band at the top is women using other forms of contraception. You may note that in this column, the percentages do not exactly equal the ones I've just presented. For example, 60% of women using the oral contraceptive pill and 45% using condoms at survey 1. This is because to make this type of transition plot, a discrete category has to be chosen at each time point. And if the woman chose more than one type of contraception, we needed to choose just one. By survey 2, you can see how some women who were using, for example, the pill at survey 1 in the green band now reported using condoms in the red, or long-acting methods in the yellow, while some women who were using condoms at survey 1 now use the oral contraceptive pill, the long-acting methods, or no contraception. So over the next 3 surveys, you can see still more transitions and changes in the women's use of contraceptive methods. I guess the takeaway message from these slides is that if you survey a woman at age 18 to 23 about what contraception she is using, you really cannot predict what she might be using 1, 2, even 3 years later. Now, the next 2 slides will show how use of the different contraceptive methods may differ by variations in women's sociodemographic or health behaviour characteristics. The results are simple descriptive associations. Where a contraceptive method is not mentioned in relation to a sociodemographic factor, it is because there were no clear differences or associations. So if we look at highest educational attainment, women with more years of education were more likely to use the pill, condoms, and the Mirena IUD, less likely to use Implanon, other contraceptives, or no contraceptives, compared to women with fewer years of education. If we look at income, women who found it easier to manage on their income were more likely to use the pill and condoms and less likely to use the long-acting methods or no contraception, compared to women who found it more difficult to manage on their income. Women who were single or in a de facto relationship were more likely to use all forms of contraception compared to women who were married. Women living in more urban areas were more likely to use the pill and less likely to use Implanon or no contraception compared to women living in more remote areas. For language spoken at home, the results are more subtle and mixed, and certainly further exploration is needed. The pill and Implanon were used in higher proportions by women who spoke English. Condoms were used less by women who spoke English, but more by women who spoke an Asian language or another language. Implanon was also used in high proportions by women who spoke an Asian language, and use of no contraception was higher over time in women who spoke a language other than English. This slide shows the use of contraceptives by some health behaviour factors. Where a contraceptive method is not mentioned, again, it means that there were no associations or clear differences. So if we firstly turn to use of contraception by use of alcohol. So women who consumed alcohol at a higher or risky level had higher use of the Mirena IUD and lower use of no contraception compared to women who consumed alcohol at a lower level. There were mixed patterns, however. For example, both the pill and implant use was lower in women who drank at rescue levels, but it was also lower in non-drinkers. If we look at how much physical activity the women did, women who were inactive had higher use of no contraception and lower use of the pill compared to women who were active, even if they were active at reasonably low levels. If we look at body mass index, women who were overweight or obese had higher use of implanon, other contraceptions or no contraception compared to use of the oral contraceptive pill. If we look at smoking, women who were smokers had higher use of no contraception, but lower use of the pill and condoms compared to women who were not smokers or who were ex-smokers. Finally, I'd like to talk about contraceptive use and use of drugs. Now, these asked in the survey were marijuana and illicit drugs, for example, amphetamines, LSD, hallucinogens, tranquilizers, cocaine, and the like. There were a mixed bag of associations, but in essence, women who reported using these drugs had high use of no contraception and lower use of the pill and condoms compared to women who either did not use these drugs or used them infrequently. So this presentation has highlighted the changes and transitions in contraceptive use by women in the early years of their reproductive lifespan. It's shown that women need choices and options and has highlighted some of the associations with sociodemographic and health behaviour factors. So the next steps include drilling deeper into these associations and also looking over time and also adjusting for other factors. We are also currently preparing a major report on reproductive health to be presented to the Department of Health in February. As well as some of the findings I have presented today, the report will cover work on determinants of some of the transitions in contraceptive use, experiences of menopause and perinatal mental health, experience of reproductive health and reproductive health services, indeed before and during the COVID pandemic. I'd like to thank you for listening. Details of the study and my contact details are here. I welcome any further queries or questions you may have. These slides will be made available after the symposiums if you want to check the details. I'd like to acknowledge the Department of Health for funding the study and the women who generously provide the data survey after survey. I would now like to introduce Dr. Melissa Harris to do her talk on the data linkage perspective of contraceptive use. After the conclusion of her talk, we will have a question and answer session. Thank you.
Today I'm going to talk about some work we are doing regarding contraception in the data linkage space. With so many contraceptive choices, deciding on what method to use is often difficult. What we do know is that upwards of 40% of pregnancies in Australia are unintended, and long-acting reversible contraception, or LARCs, are some of the most effective methods in preventing an unintended pregnancy. Despite this, the oral contraceptive pill remains the most popular contraceptive method, particularly among young women who are at highest risk of an unintended pregnancy. Health record linkage provides a different perspective to surveys, and it may assist us with filling in some of the gaps regarding contraceptive use across the reproductive life course. Today, I'm going to take you through some findings related to LARC and oral contraceptive pill use using Australian Longitudinal Study on Women's Health data linked to administrative data. Looking at LARC insertions across the reproductive life course, we linked data for the 1989 to 95 and 1973 to 78 cohorts to the MBS and PBS data sets, which were available from May 2002 to June 2020. To capture LARC insertions in the administrative data, we looked at IUD and implant insertion claims in the MBS and prescriptions for the implant and hormonal IUD in the PBS. It's important to note here that the copper IUD is not PBS listed and it can only be captured in the MBS data. We first looked at the number of LARC insertions per 1,000 women recorded in the administrative data across the period where we had complete calendar year data. This graph shows the proportion of women who had a LARC inserted for the 1989 to 95 cohort. Given the age of the women in this cohort, only insertions from 2013 onwards, when they're at least 18 years old, have been shown, as LARC use prior to this age was extremely low. As you can see, LARC insertions increased over time, and when we look at individual LARC use, we see IUD insertions increasing and implant insertions decreasing. A similar trend in increasing LARC was demonstrated for the 1973 to 78 cohort, although the trend is largely driven by IUD insertions. Examining LARC use from a different perspective, we then looked at lifetime prevalence of use. So while women from the 1973 to 78 cohort are older and have had a greater opportunity to have selected a LARC as a contraceptive method, the overall lifetime prevalence was slightly lower, with 38% having had at least one LARC, compared to 44% of women in the 1989 to 95 cohort. This slide here shows some distinct cohort differences in the type of LARC use. In the 1973 to 78 cohort, a higher proportion of women reported having an IUD, and in the 1989 to 95 cohort, a higher proportion reported implant use. Only a small proportion of women in either cohort had tried both LARC options across the observation period. So what these findings tell us is that when women decide on a LARC as a contraceptive option, characteristics of that specific LARC are important, such as the level of invasiveness in the body. This graph shows median age at first LARC insertion for both cohorts. As you can see, women from the 1989 to 95 cohort were younger across both types of LARC, but had the implant inserted earlier. From here, we examined sociodemographic and health factors of LARC insertions over time by linking the women's survey responses to the MBS and PBS. A number of factors were associated with having a LARC in both cohorts. The strongest factors for the 1989 to 95 cohort included history of pregnancy and number of children, with women who had 3 or more children having a 1.6-fold increase in odds compared to women without children. When we looked at the 1973 to 78 cohort, there were fewer factors identified, but the strongest associations were similar. We then looked at oral contraceptive pill use by linking data for both cohorts to the PBS for the period January 2003 to December 2018. This slide shows pill use over time during this period. As you can see, there is a large increase in pill use being recorded in the PBS data after 2012. Prior to July 2012, only scripts dispensed that were above the copayment amount were recorded in the PBS, and this meant that the majority of oral contraceptive pills were not captured. It's also important to note that not all formulations of the pill are captured in the PBS, particularly those of the newer generations. To see who we might be missing, we compared data from women who had a PBS listed script for an oral contraceptive pill to those that self-reported the pill in the surveys only. And what we found is that around 40% of women who self-reported the pill were not captured in the PBS data. However, when we looked at differences between these women, we found that they were largely driven by socioeconomic factors. To examine the length of time women were using the pill, we looked at the proportion of days that were covered based on date of supply and number of pills. Continual use of the pill was defined as having 80% coverage between January 2013 and June 2019. This timeframe allowed us to get the most complete picture of not only pill use, but also short and long-term use. As you can see from the graph, most periods of use for both cohorts were 150 days or less, which is equivalent to a 4-month script with 80% proportion of days covered. We then categorised women who only had periods of use of 150 days or less as short-term users, and women who had at least one period of use longer than this as long-term users. And based on our definition, 38% of women from the 1973 to 78 cohort and 25% of women from the 1989 to 95 cohort were deemed to be short-term users of the pill. We then compared these women on a range of socio-demographic and health-related factors by examining the survey that preceded the first period of use for each of the groups. As you can see here, in the 1989 to 95 cohort, short-term users differed from long-term users across a number of factors. Short-term users were more likely to be partnered, had higher educational attainment, had higher psychological distress, rated their health as poorer, had experienced a previous termination of pregnancy, were current smokers, had higher BMI, had experienced miscarriage, and had ever lived in a violent relationship. When we looked at the 1973 to 78 cohort, we found that few factors distinguish short-term and long-term users, although short-term users were slightly older and were more likely to live in a major city. When we looked at chronic conditions, short-term users in the 1989 to 95 cohort had higher prevalence of hypertension, low iron, endometriosis, polycystic ovary syndrome, and depression and anxiety. And when we looked at chronic disease in the 1973 to 78 cohort, short-term users had higher prevalence of heart disease and polycystic ovary syndrome. So where do we go from here? We are currently looking at contraceptive transitions over time, as well as what women use following discontinuation of a LARC or the pill. Given that so many women were short-term users of the pill, this is important as the pill is often cited as the prime contraceptive method at the time of an unintended pregnancy. What we want to know is, do they go on more effective methods such as a LARC? Do they elect to go on non-hormonal methods? Or do they choose to have a contraceptive break and not use contraception at all? We are also focusing our attention on contraceptive use in the perimenopause period, as this is a critical period for women in terms of the impact of chronic disease on contraceptive choices and also the risk of unintended pregnancy. I'd like to acknowledge the Department of Health for funding the Longitudinal Study, the ALSWH for undertaking the data linkage, and the Australian Government for funding support through an ARC Discovery Early Career Research Award. Thank you.
Thank you very much, Melissa. Now, I'd like to welcome questions from the audience for a question and answer session on both the talk given by myself and Melissa, before we then go on to Katrina Moss's talk. We do have a couple of questions that have been provided, and please put your questions into the Poll EV software that you should have a link to. So I haven't seen any questions on the Poll EV yet, so I might go to the ones we have on notice. So I think, Melissa, the first one here might be for you. And that question is, what are some of the things we can do to increase uptake of the long-active contraceptive methods?
Hi, Leigh. So that's not a simple question to answer. So it's contraceptive use across the reproductive life course is very complex. But some of the things that we can do in terms of increasing LARC among young women is around education, particularly for young women. Research has shown that when women are appropriately counselled in contraceptive use, and particularly in terms of side effects of each of the contraceptive methods, that has an impact on what contraceptive women take. So that's one aspect that we can look at. The other aspect is in terms of training of our healthcare force. So at the moment, and increasing access to LARCs. So at the moment, we have a shortage of GPs that have the skills in order to insert implants and IUDs. So increasing training amongst those people will help increase LARCs. Also, by extending that program and training nurse practitioners, registered nurses and registered midwives in the insertion of implants. That's been something that's been happening at the moment, but increasing that will help assist increasing LARC and also take the burden off GPs as well as to provide that whole care. So one of the other things we can do is around finance, looking at sort of incentives for providers for recommending LARC. That would also help increase LARC use among young women, and particularly reducing the cost of some of the LARCs. So women who opt for a non-hormonal method of a LARC currently have to pay all the out-of-pocket expenses for that particular method. So that's there are a couple of things that we can do to help boost LARC, and continuing research to understand, what are the barriers to LARC, because it's very nuanced. When we look at qualitative research, women choose contraceptive for a large amount of reasons, and not all of them are just to prevent unintended pregnancies. So a lot of for the non-contraceptive effects.
Okay, thank you very much. We have had a couple of other questions come in. The first one you actually touched on, Melissa, but I will read it out because I'm sure we can answer more fully. And that question was, does the study, qualitative data, give us insights in regards to the drivers for choice of contraceptives and barriers to access, and whether they are actually addressed in the quantitative or the qualitative data? We have had several publications on this, and those publications are available on our website. And I will comment first, and Melissa, you may wish to add, but certainly women report many barriers to accessing contraception, and some of those barriers include the cost, having to go back to get a repeat prescription if they live in rural areas, simply not having a GP available or not having a female GP available. They also talk about not being taken seriously by some of the healthcare providers that they talk to about their contraceptive needs and their reproductive needs, and being told and sort of feeling like they are just being told that they should do this or they should behave in this way with respect to their contraception. But Melissa, do you have anything to add to that?
Yeah, so I think part of it is confidence of health providers. The pill has been, the most popular contraceptive method since it was introduced. That's what providers are comfortable with. And particularly if you've got a woman that comes for contraceptive advice and she's outside the norm, and so someone like with endometriosis, providers sometimes don't know what to do and they err on the side of caution. So, so it brings it back to increasing education for our providers so that they can provide contraceptive counselling across the whole spectrum, because it's not a one size fits all, and women have various reasons for choosing that method. And as it was discussed in that question, some contraceptives have other benefits, such as helps with reduced bleeding and that sort of thing, and they're reasons that help assist them to choose that method.
So we now have another question, and this question is noting that some contraceptive methods, for example, Mirena, can be used for treatment of endometriosis. Have you looked at whether increasing uptake of these methods may be reducing rates of hysterectomy? Now, I don't have an answer for that. I don't know if Melissa does. I can certainly get back to the person who put that message on with a response. Melissa, do you have any comment in terms of reducing rates of hysterectomy?
We haven't looked at that, but that's a fabulous question and we should look at it. We're currently looking at the moment, for women who have chronic diseases, a range of across a number of chronic diseases, and we're at the very stages of just looking at what are their patterns of contraceptive use and what are their rates of unintended pregnancy. So that would be part of that scope of work that we take that question on note as we move forward. It's a great one.
Yeah, very good question. We have had another question about the policy implications of the changing patterns of the contraception use that we are finding in our data in terms of how policy can be planned and predicted. And I think that's also a really good question, and it's a very difficult area because women need choices and they need options, and they go on methods don't work, they come off methods. So I guess it's a question of making sure that whatever women need, the options they need are available for them, rather than trying to predict that a certain level will be attained, because there are so many factors that influence
these women's changing contraception. Now, are there any other questions? If not, we might go on to our next presentation, and then we will then have another question and answer session after that. So can I please remind people to just check your cameras turned off, otherwise you will actually be recorded. Now, I would now like to introduce Dr. Katrina Moss for her talk on pregnancy and assisted reproductive therapy.
Hi, I'm Katrina, and I'm going to talk about research we're doing on reproductive outcomes and use of assisted reproductive technology, or ART. We'll focus on the two youngest cohorts, so born in 1989 to 95 and 1973 to 78, and we'll look at both the self-report and the MBS data. We've conducted 6 surveys with the 89 to 95 cohort. This covers ages 18 to 29, so they're at the beginning of their peak reproductive years. So far, we've recorded 2,615 births, with all but 37 surviving. We've conducted 8 surveys with the 73 to 78 cohort. This covers ages 18 to 45, so they're approaching the end of their peak reproductive years. We've recorded more than 19,000 births for this cohort, with all but 184 surviving. If we compare the cohorts at equivalent ages, it gives us an insight into generational differences in birth patterns. The younger cohort were aged 29 from the year 2018, and the older cohort were aged 29 from the year 2002. The birth rate was higher in the older cohort, with 1.76 births on average, compared with 1.51 births for the 89 to 95s. At 18 to 23 years and at 22 to 27 years, the older cohort reported a higher percentage of having 1 birth and of having 2 or more births. So switching now to fertility problems, the percentage of the 73 to 78s reporting they'd never tried to conceive, which is this lightest band at the bottom, fell from 75% when they were aged 22 to 27 to 17% when they were aged 40 to 45. Across all surveys, 1 in 5 reported they'd never tried to conceive. The percentage reporting problems with fertility, which is this darkest band at the top, rose from 3.5% when they were aged 22 to 27 to 24.2% when they were aged 40 to 45. Across all of the surveys, about 1 in 5 women reported fertility problems. So in those women with fertility problems, help seeking increased with age. Around half reported seeking help when they were in their early 20s, compared to around 80% when they were in their early 40s. Of those who did seek help, just over half reported using IVF or fertility hormones, but a substantial percentage said they didn't seek any help. Comparing the two cohorts, the prevalence of fertility problems was similar at approximately the same age, about 3.5% at age 22 to 27, and about 6% at age 24 to 30. So the difference we're seeing in the birth rate between the two cohorts doesn't seem to be related to a difference in fertility problems. On the other hand, the percent reporting they'd never tried to fall pregnant was higher in the 89 to 95 cohort by almost 20% at 24 to 30 years. So that may well be what's going on here. So far, we've been talking about the self-report data from the surveys, but we've also got linked MBS data on ART for both of the cohorts. In the table, you can see the item numbers that relate to in vitro fertilisation, or IVF, and intrauterine insemination, or IUI. Different combinations of item numbers make up different cycles. So for example, a fresh embryo transfer, a frozen transfer, an IUI. But there's a great deal of inconsistency in how the cycles are billed, and to add an extra layer of complexity, some of the items changed their definition in 2010. we just finished cleaning the data set and can report some preliminary analyses that are hot off the press. So we have almost 24,500 MBS item numbers. These make up just over 7,000 cycles for about 1,500 women. This is almost $19 million in MBS benefits paid, with an average of just over $12,000 per woman, although this did range from $35 to $88,000. Women were out of pocket $11.5 million, with an average of $7,500 per woman, and this ranged from nothing to $59,000. And keep in mind, that doesn't include medication costs. Most of the cycles were IVF rather than IUI. Most women did IVF and almost 20% did both. These are the IVF and IUI cycles by age for the 73 to 78 cohort. You can see that IUI use, which is the light green, is consistently lower than IVF, which is the light purple bars, which is what you'd expect based on the numbers we saw in the previous slide. IUI use was highest at age 32 to 33 and declined from age 34. IVF use was highest at age 36 to 39 and declined from age 40. So we're seeing different patterns of use according to age. The results were similar in the 89 to 95 cohort, as in most women used IVF rather than IUI. There is a decline for IVF at age 29 and 30 years that we didn't see in the older cohort, but we're not reading too much into this because our data go up to 2020. So that may reflect difficulty accessing these types of services during COVID. Also, even though 2020 has felt like the longest year in history, it's not yet finished. So the data for this year is incomplete. Comparing the two cohorts at similar ages, the 89 to 95s, which is the light green, started IVF earlier, and they were also using it at slightly higher rates. So overall, there were no differences in fertility problems between the cohorts, but we are seeing differences in other areas. The 73 to 78 started trying to conceive earlier and had a higher birth rate. The 89 to 95 started IVF earlier and are using it at higher rates as well. So there's lots of other things we're planning to explore in this data, including the demographic and health characteristics, comparing the MBS with self-report data. And our data set's unique in that we've got women who reported fertility problems but didn't seek any help. And we're very keen to know more about these women because they're not captured in MBS and ALT data. If you have any questions, I'd love to hear from you now, or you're also welcome to send me an email.
Thank you very much, Katrina. So can I please welcome the audience to send in any questions using the Poll EF software? And please remind you again to turn your cameras off, otherwise you will be recorded. Okay, I'm just checking for questions now. So there's one here. Why do you think the younger cohort were using more IVF, even though they weren't reporting more for fertility problems? Now, I've actually got Katrina with me, so I'll get her to step in and answer.
Hi, thanks Leigh for that question. It's actually really tricky to try and think about the differences between the cohorts in their ART use. I think it's encouraging that the fertility problems reported were similar in percentage between the two, but we don't actually know yet why they were using more IVF. We do know that there's a lot of other differences between the cohorts in terms of their mental health and in some cases in health issues like endometriosis and PCOS. And so one of our next steps is to explore those differences between cohorts, because I think that's one of the powerful things about the Australian Longitudinal Study on women's health is that we have these different cohorts who have gone through completely different experiences, and that can give us some really unique insights.
Okay. Any other questions, everybody? Right, the questions come through. I'll just have to have a read. Okay, so the question says, do you think the earlier use of IVF is due to it becoming more readily available, or are there changes in the price of IVF? Katrina?
That's definitely something we're going to be exploring. So at the moment, we're going to be looking at what the different cost comparisons were, but we do know that IVF benefits have changed and IVF definitions have changed. And some of the public health messages about being aware of your fertility and being aware of issues like endometriosis may well be getting through to the younger women more than they got through to the older women. So what we will be trying to do is try and figure out what are some of the barriers, enablers that the two different cohorts experienced. And I think cost may well be one of the major ones.
Okay. Any other questions? Please feel free also to email us if you have any other particular queries that we may not get to today. One other is with the MBS data, you talked about the number of cycles overall, but how many cycles did each woman actually do?
I think that's actually a really important question, because what we know is that people do IVF obviously for the outcome of a live birth, but not everyone achieves that. And the women who are doing more cycles are potentially going through more cycles of grief and loss. They're also having more medication. And we know from other research from this study that estrogen exposure can have different effects on women's long-term cardiovascular outcomes. So number of cycles is actually a key thing we're interested in considering, both in terms of women's psychological health and how it might be affecting them into the future. I broke down the number of cycles per woman, and it averages at about 4.6 cycles per woman with a median of 3, but it does range from 1 cycle to 36 cycles. So there's a huge amount of variation going on there, and that may well come down to the health issues that women are experiencing.
Okay, thank you very much. Okay, well, there don't seem to be any other questions. So unless one comes through in the next, here we go. They're coming in now. Okay, so, right. So here we go. The out-of-pocket cost per woman is extremely high. Not really a question, but a comment that this seems like it would be a massive increased financial burden. Would you like to comment?
I think that's an excellent point. MBS makes a huge contribution to, this part of women's reproductive journey, but it doesn't cover everything. And what we looked at today doesn't also include the medications, which can incur a lot of out-of-pocket costs. So that financial burden, as you really accurately named it, just increases the overall burden of this kind of assisted reproductive technology, and really can impact the couples that are having to undergo this type of therapy. So that's something that we're going to be exploring when we look at women's psychological impacts from using this form of reproductive technology. And there's another question about whether the study explores women from the LGBTIQ+ communities accessing IVF. Just noting that they haven't always had access to these services because of their gender identity in Australia. I haven't actually got that down to something to explore, but I think it's an excellent point. And we do have several women from that community who identify. So I'll note that down as something that we might explore. Whether or not we have the numbers to delve into it, I don't know, but certainly we can report on prevalence, which I think is really key. So thank you for raising that. And we've just had another question about whether we can link women and number of cycles with live births by age group, especially over 40. Yes, we absolutely can. So that's one of my biggest questions too, is what's the outcome? Women and couples do this because they want the outcome of a live baby they can take home from the hospital. And we know that doesn't happen for everyone. So I was anticipating someone else might be interested in that as well. So I quickly ran some figures this morning and looking at women who answered in the 73 to 78 cohort who answered surveys 7 and 8. So we know that we've most likely got data on their births. What I found was that 21% of those women did not report a live birth to us. So, you know, that's 20% of women undergoing IVF or IUI or both who don't get the outcome of a live baby. So we will definitely be exploring that further in our major report and also looking at it by age and also health issues like endometriosis and PCOS, which just make reproduction even more challenging. Fantastic questions though. So another one's come through. So similar to the previous question, can we link data on the relationship status of women doing IVF? Are there more single women pursuing this as a method for having children alone? Absolutely, we can do that. So we have women's partnership status in the data, and that's one of the key variables we'll be analysing, but I haven't done it yet. So some of the things I've been reporting on, I only finished cleaning the data on the weekend and only ran the analyses early this week. So we've got a whole list of things we're interested in exploring. We think it's such an interesting topic, and this study gives us a really unique way of having a look at some of that data, but we will definitely be looking at it by partnership status. I think that's all the questions for now, but you know, feel free to email me if there's something else you're really keen to know. I'm very happy to engage in a discussion.
Okay, so Katrina's details will be available at the end of her presentation slides. A last minute one. Here we go. This is fantastic, guys. So this question says, would be good to provide more cost data, especially for live birth outcomes for older women and the public-private split.
Yeah, that's definitely something we can look at, cost for live births for older women. I don't know that we have the public and private split in our data though. We may well be able to get that from our perinatal linked data, but may not be able to include that in the report, but that could be something we could look at down the track. And another question came through with the partner question, will we explore LGBTQI relationships in increased IVF usage? Yes. So I think that's a really important point that's been raised this morning, and it's something that I'm going to add to the demographic characteristics that I'm going to be exploring. Yeah, I think that's incredibly important. So thank you very much for bringing that to my attention.
Yeah. Okay. All right. So unless we have any last minute ones, but of course we can always reply later, I think I might wrap up today's session. So I'd like to thank you very much for attending the session on reproductive health. We hope you found it interesting, and more importantly, we hope you found it relevant to your work. We hope that you will join us tomorrow for the session at 12 o'clock, which will be presented by Deb Loxton about the women's experience during the COVID pandemic. Thank you very much.